Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalata from Roots Community Health Center, reporting for the week of June 5th, 2023. Following a status update on COVID and on Paxlovid, I will review the relationship between COVID and asthma. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look at the new CDC COVID data tracker, we can see that hospitalizations are continuing to trend down as of the end of May. But unfortunately, we do see a slight uptick in deaths over the past week. So that's something we'll definitely continue to keep an eye on. So far, over 1.1 million people in the United States have died from COVID. 38,529 of those were just this year in 2023. And we have had a continued trend of weekly deaths coming down, with the week ending May 6th being the lowest of the entire pandemic at 856 deaths. This is the 5th week in a row that the deaths were trending down, but again, note that this was the week ending May 6th, so that's already a month ago. And as I showed on the previous slide, we are already trending up. So hopefully the upward trend will not continue, but we'll keep an eye on it. As far as hospitalizations, we've been somewhere around 7,000 to 8,000 new admissions per week nationwide. And if we want to understand more about hospitalizations and emergency visits, the new CDC map is helpful. It's still a bit unclear how complete and timely the reporting is from each of the counties. But for example, if we want to look at hospitalizations right now, we can see that hospital admission rates are considered low in pretty much the entire country, with the exception of a handful of counties in the state of Texas. And if we want to understand how this is changing, we can take a look at the percent change from the prior week. And when we do that, we can see kind of a mosaic here, with some areas in the orange and red that are increasing, and the ones in the green are decreasing, and the ones in yellow are stable or relatively unchanged. So this will probably be the most helpful when we see large swaths of change in one particular area, for example, or this could be helpful for you to drill down on what is happening in your particular county. And the link to this map is in the post. And taking a look at emergency visits, and this is by state. And as we can see here, if we're just looking at the percent of emergency department visits with COVID, that the entire country is considered minimal. And then we have a few states here, Oklahoma, Missouri, Minnesota, that are not reporting at all. But if we want to get an idea of what's changing, again, we can look at the percent change of emergency department visits compared to the week before. And as you can see here, there are some states that have some substantial increases. And these are up here in the northeast corner of the United States. So specifically, Maine and Connecticut have substantial increases compared to the week before. And this is something that will be important to keep track of, because emergency department visits are a relatively earlier sign of a potential surge. So this is something that we will definitely continue to monitor. And speaking of what's going on in the northeast corner of the United States, there are some reports of high concentrations of SARS-CoV-2 detected in all 14 of New York City's wastewater treatment plants. So this is not a good sign, but I think it's a good thing that we are seeing reports regarding wastewater in the media, which hopefully will help residents of that area take heed, because this may certainly be an early sign of an upcoming surge. So we don't know that for sure yet, but if we see increases in wastewater, then we see increases in emergency department visits in the same area, then I think that would be a good indication that cases are rising and it might be time to exercise more caution. Now, taking a look at variants, I don't have a lot to say here. We are really still dealing with all XBBs, so this is still a subvariant of Omicron. They're all incredibly contagious. We don't know of many big differences between these different XBBs. At this point, we're just hoping not to see anything new. I'd rather be dealing with the variants we know than contending with anything new, so we'll just keep watching. I want to report some good news regarding Paxlovid, which is our #1 COVID treatment choice for most of those who need to be treated. It has finally received full authorization after being under emergency use authorization for over a year now. So what does this mean? Well, first off, I think that for anyone who had concerns about it being under emergency use authorization, this should lay those concerns to rest. We've now had quite a bit of time, quite a bit of data, and it has met some very rigorous standards and is now fully approved. So that's a good thing. The other thing it means is that the manufacturer will be able to advertise, which in theory they're not supposed to be able to do until they have full authorization. But I think what's most significant here has to do with the flexibility that prescribers will now have. When a medication is under emergency use, prescribers have to stick only to what's in that authorization and cannot go outside of that at all. Now, when might we want to go outside of what's in the authorization? Well, the main situation that has come up in practice for us would be our ability to prescribe for someone in anticipation of a need, even if they don't need it quite yet. One thing that does come up a lot and may be coming up more over the summer for some of you that might be going on travel and you may be going somewhere where accessing Paxlovid would be difficult. Previously, we really didn't have the leeway to go ahead and prescribe it to you because the emergency use authorization specified that you had to have symptoms, you had to have COVID in order to get the prescription. So I believe that having the full license removes that concern. So if you're planning to travel away from where you would be able to be prescribed medications by your doctor, this could even be in the United States, but certainly abroad, then before you go, you should have this conversation with your physician and get all the instructions and even get the prescription for Paxlovid if they agree. Another situation can be for caregivers of someone who has maybe who is not very mobile, that having a prescription on file so that once they're tested and they're positive, that they can easily go pick up that prescription within the appropriate window of time. So I think there are situations where physicians might want to be proactive, and now they are able to do that. It is important to note that there are many medication interactions that have to be reviewed very carefully by your doctor if you're on other medications. Most of these issues can be addressed by having you pause your medication while you're taking Paxlovid. So in most cases, this is not a reason to avoid treatment. The other concern that has been overblown about rebound, we've gone over this many times, it happens with Paxlovid, it happens with placebo, it happens with other treatments, it happens without any treatment. So this should never be a reason not to take treatment. And sadly, I've heard even doctors confused about this. So maybe now that there's full authorization, the drug company will be doing more educating of the public as well as doctors. And so hopefully we will not have so many barriers to actually receiving this life-saving treatment. And in the event you are one of the rare people who cannot take Paxlovid, who really cannot take Paxlovid, remember that there are other treatments. There's a second-line treatment called remdesivir that is given by IV. That would be the second choice, although it may be difficult to access because it is an IV infusion. And last and least is molnupiravir, which is not as effective as Paxlovid or remdesivir, but it is better than being untreated if you're at risk of a serious outcome. One thing to note is that the full approval for Paxlovid is for adults 18 and up, but as you can see, Paxlovid is actually approved down to 12 through the emergency use authorization. So the emergency use authorization is actually going to remain in place for now as they finish doing the evaluation for Paxlovid in children and get a fully authorized preparation for them. But right now, if there is a child, so anyone under 18 can still, or from 12 to 17 can still access the Paxlovid through the emergency use authorization. And the emergency use authorization will Also make it so that Paxlovid will be available and free until they run through the current stockpile that they have of quite a lot of Paxlovid. But after that point, it will become a commercial product that will be sold the same way other medications are sold. But until then, it is free and it should be accessible to anyone who needs it. And how do you know if you're someone who should take treatment if you get COVID? Treatment is recommended for everyone 50 and up. Everyone 50 and up. And anyone with an underlying condition. And the list of underlying conditions is a very long. It includes very common things. Some estimates say that up to 3/4 of the adult population actually fit into this category of people at risk of a severe outcome. So check out the list. The link is in the post. Please make a treatment plan. So now I want to talk a little bit about COVID and asthma. Most people, I think, are familiar with asthma, but it's a condition where a person can have trouble moving air in and out because they can have their airways become inflamed or narrow or get swollen, produce a bunch of mucus, can make it difficult to breathe, and it can be anywhere from very mild to very severe. It's a very common condition. And when the pandemic first started, we were so concerned about people with asthma because asthma is so common. And typically, people who have asthma can do worse when they get a viral respiratory infection compared to others. It can trigger their asthma symptoms. It can progress into more severe disease. So naturally, we were very concerned that the same thing would happen with COVID. But before long, we realized that somehow people with asthma actually did not do worse than others when they caught COVID. And in fact, there was some indication that they might even do a little better in some cases. Now, there have been a number of studies trying to understand why this might be. I'm not going to go to them in too much detail, but there have been a couple of interesting findings. It might have something to do with the ACE receptors. There's some suggestion that people with asthma actually end up having fewer ACE receptors. So that means fewer sites for the SARS-CoV-2 to latch onto. Also, people with asthma and actually other allergic conditions produce different proteins. In particular, there's a mucus protein that people with asthma produce a lot of that appears to actually protect them from COVID. So some theories and evidence about why, but the bottom line is that it turns out that people with asthma have very similar risk as others, not an increased risk, very similar risk as others of getting COVID, of being hospitalized with COVID, of needing help with their breathing, with mechanical ventilation, not an increased risk. And some studies have even shown a lower rate of hospitalization and mortality among people with asthma. So it came as a great surprise, a pleasant surprise, that people with asthma do not do worse in the acute phase when they first get sick with COVID. May even do a little bit better, not protected by any means, but definitely not what we had feared. So that has been well established now. But notice I said in the acute phase. So when you first get COVID, that initial period. What we don't know as much about is what about after you have COVID. And it turns out that there's not a huge amount of evidence of what happens to people with asthma after they've had COVID. So what happens in the weeks and months afterwards? We know that there are a lot of post-COVID and long COVID challenges that can happen to people, whether or not they have asthma or any underlying condition for that matter. This study that just came out May 19th of 2023 looks specifically at the respiratory challenges that happen after COVID. I'm not going to actually go into this article in too much detail today. I'm going to save it for next week when I focus on long COVID, because it talks about a number of different reasons why people end up with prolonged symptoms of shortness of breath and difficulty breathing or cough after they have COVID. But I did want to point out one key message from this article. It reiterates that individuals with well-controlled pre-existing respiratory conditions, including mild to moderate asthma, do not appear to be at increased risk of severe COVID-19. And this is the important part. They say, however, people with asthma or COPD might have an increase in symptoms after COVID-19. There was also a very large Veterans Affairs study of what happens to people post-COVID-19 infection, and they found that respiratory symptoms were the most common burden that people had at the 6-month mark after their COVID. So 6 months after having an acute infection, folks were still having respiratory symptoms. And it also showed a higher use of inhaler medications among those people. That was whether they had asthma or not. But again, both of these studies are talking about what happens to the general population after they get COVID and showing that they have persistent respiratory symptoms and that they might even need to use an inhaler, regardless of whether they had a diagnosis of asthma before they caught COVID. So this is, of course, a huge concern if people never had asthma and now they're developing these type of symptoms after the infection. But what I want to talk about today is people who already have asthma. What does it look like for them if they catch COVID-19? Now, we've already said that they're not at a particular increased risk of a bad outcome from their acute infection, and that's good. But what about after that? This study was published in March 2023 in the Journal of Allergy and Clinical Immunology and Practice called Post-Acute COVID-19 Respiratory Symptoms in Patients with Asthma, an electronic health records-based study. So this is one of the few out there that is specifically looking at a population of people with asthma and trying to understand what happens to them after that acute COVID infection. So they looked at people who caught COVID between March 2020 and January 2021, and then they included 180 days or 6 months of healthcare follow-up in a healthcare system in the Northeast United States. This study used something called natural language processing to basically mine through the patient charts to see what they could find. And I thought this was actually interesting because we know that not every single symptom is going to be coded or billed or structured in a way where you can easily run a report from the record, like a lot of the research that we do. If someone comes in having symptoms that get noted in the chart, then this natural language processing can actually identify it, even if it wasn't something that was coded. And they use some different types of analysis to compare symptoms in patients with asthma and those without asthma, and they adjusted for all those important clinical and demographic factors. They took a look at 31,084 eligible patients with COVID-19, and out of those, 4,049 had a history of asthma. And they were fairly evenly split between hospitalized and non-hospitalized patients. When they looked in the post-acute COVID phase, that 6-month period after COVID, they found that patients who had asthma had a significantly higher risk of shortness of breath, of cough, of wheezing, of bronchospasm, which is that when the airway spasm, and that's what causes some of the wheezing and difficulty breathing. And these were all increased compared to patients without a history of asthma. And this was also true of patients who had not been hospitalized with COVID. And this was even true of patients who had very well-controlled asthma before COVID, and even in patients who had not been experiencing those same symptoms before they had COVID. For example, among patients with asthma who were hospitalized, 75% of them had documented bronchospasm after COVID, even if they had not had that before COVID. And in the non-hospitalized group, 64% of them had the bronchospasm after COVID. One thing of interest is that about 6% of the patients who had never had asthma ended up having bronchospasm and wheezing after COVID. And those symptoms, the wheezing and the bronchospasm, those are really considered hallmarks of asthma. And this is consistent with those studies I mentioned earlier about people who never had asthma before now having symptoms of asthma after COVID. So in summary, people with asthma don't have an identified increased risk of infection with COVID or even increased severity of acute COVID, even though that is something we had presumed early on. However, it does appear that patients with asthma have a significantly higher risk of multiple respiratory symptoms, including brand new symptoms, up to 6 months after acute COVID compared to those who don't have an asthma history. And we don't know yet what will happen after the 6-month mark, if it's going to improve or if it's going to persist or if it's going to get worse. More time will tell. And it also does appear that patients can develop what looks like new onset asthma following COVID infection, even if they never had it before. So as we've been saying, our best bet is to avoid getting COVID in the first place. And if you're someone who should be treated, get treated. There's still a fair bit of COVID circulating, although this has tended to be the time of year with the lowest circulation here in the United States. But despite this, we still have around 8,000 hospitalizations and 1,000 deaths every single week. This is still too high, especially considering we're in our low months. Many of these hospitalizations and deaths could be prevented with timely treatment. But you can only get timely treatment if you get timely testing. Find out where you can get tested. Get your free rapid test from your insurance company or from your local community health center like Roots. Remember that we are still learning about the effects of repeat infections. We're still learning about post-COVID. We're still learning about long COVID. What we do know is that if you caught COVID once and you did fine, that is not a guarantee about the next time. So please do what you can to avoid getting infected or reinfected, and please avoid spreading it to others. Gathering outdoors is always safer than indoors. If you will be gathering indoors, make efforts to improve indoor air quality, like adding HEPA filtration units, keeping central air running with a MERV 13 or higher filter, opening doors or windows. If you must spend time indoors with others, especially members of the public, wear a high quality filtration mask like an N95, a KN95, or a KF94. If you get exposed or if you have symptoms, conduct a rapid test every day or two while continuing to wear a filtration mask around others. If you are someone you spend time with unmasked would be treated for COVID, then we need to be extra vigilant. Get tested right away. You may want to go ahead and get that more definitive PCR test since antigen tests take longer to turn positive. Remember, you generally only have 5 days to start treatment, and the sooner the better. Outpatient treatment reduces the risk of COVID hospitalization and death by about 80% in those who are at risk. Please don't show up to work or school feeling sick and exposing others. Staying home and resting is best, but if you must go out, a well-fitted N95 mask could keep you from sickening or even killing another person. Consider using rapid tests for pre-event testing, and whoever is positive needs to excuse themselves. Also, keep a guest list so if someone turns positive later, you can contact the group. If you test positive, contact anyone you've been around, especially unmasked, for the last 3 to 4 days before you started symptoms or tested positive. It is the right thing to do. And please do an antigen test to exit isolation. In general, we believe that enough virus to detect is enough virus to infect. Also, please don't push yourself. Allow yourself the time you need to fully recover. And remember to eat a balanced diet, incorporate fruits and vegetables, avoid sugary drinks, consider a multivitamin supplement, get a checkup. Make sure you have a primary care doctor and go use them. Get your blood pressure checked. Get your baseline labs checked, like sugar, cholesterol, vitamin D. Get some regular physical activity unless you're sick. In that case, please get your rest. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.